Hi, good morning. Today we are going to discuss rheumatic heart disease, and in rheumatic heart disease we are going to cover the mitral valve disease, of course, which will include both stenotic as well as recursitant disease. So before we embark on that journey, it's extremely important to understand the mitral valve anatomy, because any component of the mitral valve apparatus, if it's not working appropriately, it will result in the dysfunction and can produce mitral rebirth. As we all know, the mitral valve is present between left atria and the ventricle. There is anterior mitral leaflet and posterior mitral leaflet, and these leaflets are connected through chordae tendineae to papillary muscles, and the papillary muscles are attached to the left ventricular myocardium. So mitral annular ring, mitral leaflets, chordae tendineae, papillary muscles, and left ventricular myocardium. This all constitutes mitral valve apparatus, and any component of it is not working appropriately will result in mitral regurgitation. And if you see here, this frame is in diastole as the mitral valve is open, and there are chordae tendineae which are relaxed, and there is a dilated left ventricle. So, what are the questions one should ask in a patient who is presenting with the valvular involvement, and if he or she needs a valvular intervention? The first question you have to ask and assess: is valvular heart disease severe? Does your patient have symptoms which can be attributed to the underlying valve disease? What are the patient life expectancy as well as expected quality of life? Do the expected benefits of intervention versus spontaneous outcome outweigh its risk? And what are the wishes and preferences of patient? And are local resources optimum for the planned intervention? And if not, where your patient can be sent, where the optimal resources are available. So if you look regarding the etiology of single valvular heart disease, and this is the data from Euroheart survey, if you look for aortic stenosis, it is the degenerative which is the most common. In contrast, if you look to mitral stenosis, it is the rheumatic which is the most common. And of course, in aortic and mitral regurgitation, in between other etiologies which one has to consider instead of degenerative and rheumatic, are endocarditis, inflammatory, congenital, and ischemic. Now, looking into the major causes of mitral stenosis, of course, the rheumatic fever and rheumatic heart disease is the most common cause. Sometimes the congenital MS can be produced by parachute valve or triatriatum. In old days, severe mitral annular calcification with the leaflet involvement. Sometimes in collagen disorders, it's rare. In SLE and rheumatoid arthritis, LA myxoma can produce mitral valve obstruction, and infective endocarditis with large vegetations can lead to mitral valve obstruction. Regarding the pathophysiology in mitral stenosis, in normal adults, the area of the mitral valve is 4 to 6 centimeter per square foot. When the orifice area is reduced to less than 1.5, the LA pressure of 25 millimeters of mercury is required to maintain a normal cardiac output. So, when the area is reduced, there is increased LA pressure, which results in elevated pulmonary venous and pulmonary artery wedge pressures, reducing pulmonary compliance, contributing to exertional dyspnea. The first bouts of dyspnea are usually precipitated by clinical events that increase the rate of blood flow across the mitral valve, resulting in further elevation of LA pressure. As increase in heart rate shortens diastole proportionally more than systole and diminishes the time available for flow across the mitral valve. So any condition which will produce tachycardia will increase LA pressure and will result in dyspnea. As atrial fibrillation augments the transvalvular pressure gradient and elevates further the LA pressure, and that's why the patients of severe mitral stenosis, when they go from normal sinus rhythm to atrial fibrillation, suddenly the patient presents with a flash pulmonary edema. Now, the passive backward transmission of elevated LA pressure as pulmonary arterial constriction, the so-called second stenosis, which presumably is triggered by LA and pulmonary venous hypertension, interstitial edema in the walls of small pulmonary vessels, and at the end stage, organic obliterative changes in the pulmonary vascular bed leading to severe pulmonary arterial hypertension, which results in RV enlargement, secondary TR, PR, as well as right-sided heart failure. The LV diastolic pressure and ejection fraction are normal in isolated MS. Now, the clinical features of mitral stenosis, as we discussed, exertional dyspnea and later on even dyspnea at rest, is caused by pulmonary congestion and low cardiac output. Fatigue, of course, by low cardiac output. Edema, ascites, palpitation is produced by right-sided heart failure. Palpitation is produced by usually atrial fibrillation. Hemoptysis is produced by pulmonary congestion and pulmonary embolism. Cough, pulmonary congestion, chest pain by pulmonary hypertension, and thromboembolism due to the formation of clot in left atrial appendage as well as in LA, especially when the atrial fibrillation is there. Regarding the signs, we can have atrial fibrillation leading to atrial dilatation, produces atrial fibrillation. Mitral phases are produced due to low cardiac output, and auscultatory findings are loud first sound, a opening, a snap, and a mid-diastolic murmur. So these are the three classical auscultatory features of mitral stenosis: that the loud S1, an opening, a snap, as well as and a MDM at apex. But the valve becomes calcified, opening a snap disappears. And all these features are caused by pressure gradient across the mitral valve. Of course, because of the back pressure in the LA, and ultimately leading to pulmonary venous hypertension. There is a leakage of fluid into the pulmonary interstitium, causing craps and ultimately pulmonary edema. Right-sided failure can cause pleural effusions, and severe pulmonary hypertension can cause parasternal heave and loud P2, producing a murmur of PR as well as TR. So, symptoms: exertional dyspnea or cough may be precipitated by sudden changes in the heart rate, volume status with severe exertion, excitement, fever, severe anemia, paroxysmal AF, and other tachycardia. Even sexual intercourse, pregnancy, and thyrotoxicosis can precipitate. Dyspnea progresses and the patient becomes limited in daily activities, ultimately landing on orthopnea. Palpitation usually caused by atrial fibrillation, and hemoptysis results from rupture of pulmonary bronchial venous connections secondary to pulmonary venous hypertension. It occurs most frequently in patients who have elevated LA pressures without markedly elevated pulmonary vascular resistances and is rarely fatal. Inspection and palpation occur in patients with severe hemorrhage. There may be malar flush with the pinched and blue faces. In patients with sinus rhythm and severe pulmonary hypertension, the JBP with the prominent A waves. Systemic arterial pressure is usually normal or slightly low. A parasternal heave due to right ventricular hypertrophy, a diastolic trill due to the MDM at apex, especially in the left lateral position. Auscultation S1 is usually accentuated in the early stages of disease and slightly delayed. P2 also is often accentuated with elevated PASP, and two components of second half sounds are closely split. The opening snap of the mitral valve is most readily audible in expiration at or just medial to the cardiac apex. This sound generally follows the sound of aortic valve closure. The time interval between A2 and OS varies inversely with the severity of MS. OS opening snap is followed by a low-pitched rumbling metastolic murmur with pre-systolic accentuation. Heard best at the apex with the patient in left lateral decubitus position. It is accentuated by mild exercise carried out just before auscultation. In general, the duration of this murmur correlates with the severity of the stenosis in patients with preserved cardiac output. Soft grade 1 or 2 to 4 systolic murmurs may be heard at medial to the apex, may signify mixed mitral valve disease with regurgitation. And of course, the signs of right-sided failure in the form of increased JVP, hepatomegaly, ankle edema, and ascites, and right-sided pleural effusion may be found. Associated lesions with severe PH, you have got a pansystolic murmur produced by functional TR. When cardiac output is markedly reduced in MS, the typical auscultatory findings, including the diastolic rumbling murmur, may not be detectable, and then it's called silent MS. Loud palpable P2 with early diastolic murmur of PR in pulmonary area is due to the severe pulmonary artery hypertension. And here it is nicely depicted: loud S1, then prominent P2 followed by opening snap, and then mid-diastolic murmur with pre-systolic accentuation. So these are the classical findings which we see in patients of mitral stenosis. So mitral stenosis, one has to remember, it is rheumatic, symptoms of pulmonary venous hypertension, Symptoms of left atrial enlargement in the form of dysphagia, hoarseness of voice. Symptoms of pulmonary artery hypertension leading to right-sided heart failure. And on cardiovascular examination, tapping apex beat, diastolic thrill, left parasternal heave, loud S1, opening snap, mid-diastolic murmur with or without pre-systolic accentuation. Investigation, ECG, you can find P mitral or atrial fibrillation, RV hypertrophy in the form of tall R waves in V1 to V2. Chest X-ray, straightening of the left border, enlarged left atrial and appendage, and signs of pulmonary venous congestion. Echo, of course, thickened mobile curves, reduced mitral valve area, enlarged LA, and the gradient across the mitral valve, all will diagnose mitral stenosis. Doppler pressure gradient across the mitral valve, increased pulmonary artery pressure, and normal LV functions. Cardiac cath is usually done to exclude coronary artery disease and to detect the mixed lesions. ECG in mitral stenosis I have already elucidated earlier. It could be normal or it may show pathological changes in the form of left atrial hypertrophy causing P mitral, or increased voltage in the later part of the P waves gives it a large bifid appearance in atrial fibrillation is present in 60 to 70%. Right ventricular hypertrophy with dominant R in V1 and V2 and right axis deviation. And this is the classical sinus tachycardia, RVH, RAD, and LAO along with an attack. Checks X-ray, straightening of the upper left border, prominence of main pulmonary artery, and of course pulmonary congestion in the form of curly V lines. Here you can see there is a straightening of the left border and the enlarged LA. Double density shadow of LA is classically seen, and there is prominent pulmonary trunk as well as congestion leading to pulmonary B lines, as well as there is a right-sided pleural effusion as there is obliteration of right semiacal. Echo is the hallmark which will diagnose mitral stenosis. TT provides measurement of mitral inflow velocity during early E wave and the late A wave in patients in sinus rhythm. Diastolic filling, estimates of transvalvular peak and mean gradient, and mitral valve area. One can assess the presence and severity of any associated mitral regurg. Extent of leaflet calcification and restriction and degree and distortion of the subvalvular apparatus, and the anatomical suitability for percutaneous mitral balloon valvotomy is done by mitral valve scoring, and if it is less than 8, the valvotomy can be done if there is no significant amount and of course no clot. In addition, TT provides an assessment of LV and RV function and chamber sizes, an estimation of PH systolic pressure based on TR jet, the presence and severity of any associated valvular lesions such as aortic stenosis, regurgitation, and arrhythmias. So, echo is extremely important to assess the severity of mitral stenosis, other associated lesions, pulmonary artery pressure, presence of clot, and other lesions. And here is the 2D pictures. You can see the mitral valve is thickened and calcified. There is involvement of subvalvular apparatus involving polytendony and enlarged LA. And this is the apical four-chamber and long axis view depicting severe mitral stenosis as well as pulmonary artery hypertension with dilated right-sided chambers. And here is the flow across the mitral valve. Cardiac cath, left and right heart catheterization can be useful when there is a discrepancy between the clinical and non-invasive findings. And sometimes to detect the coronaries, cardiac cath is required. Sometimes CTA can be utilized for excluding CAD, and of course the cath is required when you are planning to do a percutaneous balloon mitral valvotomy. Differential diagnosis of mitral stenosis and MDM. Of course, we all know the significant MR can produce an MDM due to the increase in transmitral flow. Apical metastolic murmur, sometimes associated with increased flow across the mitral valve due to severe AR as Austin Flint. Tricuspid stenosis, right-sided functional murmur across the tricuspid valve in large ASD, and of course LA myxoma. Regarding the medical management of mitral stenosis, penicillin prophylaxis for group A beta hemolytic streptococcal infection for secondary prevention of rheumatic fever is important at risk patients with rheumatic MS. Recommendation of infective endocarditis, including patients with a history of endocarditis. So it is only required when there is a previous history of infective endocarditis, otherwise not. In symptomatic patients, some improvement usually occurs with restriction of sodium intake and small doses of oral diuretics, beta blockers, or other rate reducing agents at 9-hydropyridine CCBs and digitalis, especially in patients who have gone into atrial fibrillation. Of course, warfarin therapy with a targeted INR of 2 to 3 should be administered indefinitely to patients with MS who have atrial fibrillation or evidence of thromboembolism. DOACs are not considered in severe and moderately severe stenosis, except in mild rheumatic mitral stenosis, the DOACs can be considered. Conversion to sinus rhythm is rarely successful or sustained in patients with severe MS, particularly those in whom the LA pressure is high and LA is enlarged, and in whom the AF is chronic, lasting beyond a year. Mitral valvotomy, unless there is a contraindication, mitral valvotomy is indicated in symptomatic NEHA class 2 to 4 patients with isolated severe MS with mitral valve area less than 1 centimeter square. Valvotomy can be carried out either percutaneously or surgically. In percutaneous mitral valve balloon valvotomy, a catheter is directed into the LA after the transeptal rupture, and a single balloon is directed across the mitral valve inflated in the valvular orifice. Ideal patients have relatively pliable leaflets with little or no commissural calcium. In addition, the subvalvular structures should not be significantly scarred or thickened, and there should be no LA thrombus. The short and long-term results of this procedure is appropriate patients are similar to those of surgical valvotomy, but with less morbidity and a lower peri-procedural mortality rate. So it is preferred in suitable patients. Event-free survival in the younger patients with pliable valves is excellent. Therefore, percutaneous While balloon valvotomy for mitral valve has become the procedure of choice for such patients when it can be performed by a skilled operator in a high volume center. Successful valvotomy is defined by a 50% reduction in the mean mitral valve gradient and a doubling of the mitral valve area. Successful valvotomy either achieved by balloon or surgical. TT is useful in identifying patients for percutaneous procedure, but TE is performed routinely to exclude an LA thrombus and to assess the degree of MR. And at the time of scheduled procedure. An echo score has been developed to help guide decision making. The score accounts for the degree of leaflet thickening, calcification, and mobility, and for the extent of subvalvular thickening. A lower score predicts a higher likelihood of successful balloon valvotomy. If PMBV is not possible or unsuccessful, or in many patients with re-stenosis after previous surgery, an open surgical valvotomy is considered. In pregnant patients with MS, valvotomy should be carried out if pulmonary congestion occurs despite intensive medical therapy, and PMBV is preferred strategy in this setting and is performed with TEE and no or minimal exposure to radiation. The criteria for mitral valvotomy, of course, significant symptoms, isolated MS, no trivial MR, mobile non-calcified valve, subvalvular apparatus is not involved, LA is free of thrombus, and it is clearly depicted here. You have to pass the catheter, rupture the intra-arterial septum, inflate the balloon across the mitral valve, and there should be a significant reduction in the gradient and increase in the mitral valve area. And here also it is, the whole procedure has been nicely depicted, how the catheter has crossed the intra-arterial septum, placed across the mitral valve, and then balloon is inflated, and lastly fully inflated balloon resulting in balloon valvotomy. MVR is necessary in patients with MS associated significant MR, those in whom valve has been severely distorted by the previous transcatheter or operative manipulation, or those in whom the surgeon does not find it possible to improve the valve function significantly with valvotomy. Overall 10-year survival of surgical survivors is 70%. Long-term prognosis is worse in patients more than 65 years of age and those with marked disability and marked depression of the cardiac output preoperatively. Severe pulmonary hypertension and RV dysfunction are additional risk factors for the poor outcome. Now let's move on to the another lesion involving the mitral valve, that's the mitral regurgitation. And as I explained earlier, that you have to remember the mitral valve apparatus, and any component of mitral valve apparatus, if it is not functioning normally, you can have mitral regurg, including mitral annulus, mitral leaflets, both AML and PML, which are further divided into A1, A2, A3 and P1, P2, P3. Anterior leaflet divided into 3, A1, A2, A3, and posterior leaflet P1, P2, P3. Then chordae tendineae and the chordae tendineae are attached to papillary muscles, and the papillary muscles are attached to the LV myocardium. So any of the component is not working appropriately would result in mitral regurg. And as we are all aware, the commonest cause of LV enlargement is the heart failure, and when LV gets enlarged, the mitral annulus gets enlarged and produces functional mitral regurg. Regarding the etiology, mitral rigors may result from abnormality of the disease process that affects any one or more of the five functional components of the mitral valve apparatus, including leaflets, annulus, chordae tendineae, papillary muscles, and subjacent myocardium. Acute MR can be caused by infective endocarditis, papillary muscle rupture, especially in post-MI, caudal rupture or leaflet, flail leaflet in mitral valve prolapse, and a blunt trauma. Chronic is usually primarily affecting leaflets and chordae. Myxomatous, of course, in mitral valve prolapse, rheumatic fever and rheumatic heart disease, infective endocarditis, congenital in the form of cleft mitral leaflet, AV canal, and radiation. Secondary involved leaflets, chordae, ischemic cardiomyopathy, dilated cardiomyopathy, HOCM, chronic atrial fibrillation with LA enlargement and annular dilatation, and of course, mitral annular calcification. Now, primary versus secondary MR. Primary MR, in which the leaflets and chordae tendineae are primarily responsible for abnormal valve function, and secondary functional MR, in which the leaflets and chordae tendineae are usually normal, but the regurgitation is caused by LV remodeling with annular enlargement, papillary muscle displacement, leaflet teething, or their combinations. Patient assessment, treatment approach, and long-term prognosis differ significantly between primary and secondary MR. And one has to remember MR begets MR, means MR leading to LV dilatation, which leads to annular dilatation, which will produce more MR. So that's why it is called MR begets MR. Pathology, pathophysiology in mitral regurgitation, LV volume increases progressively with time as the severity of regurgitation increases and as LV contractile function deteriorates. This increase in LV volume is often accompanied by reduced cardiac output. LV compliance is often increased, and thus LV diastolic pressure does not increase until late in the course. Regurgitant volume varies directly with the LV systolic pressure and the size of regurgitant orifice. The latter in turn is influenced by the extent of LV and mitral annular dilatation. Because ejection fraction rises in severe MR in the presence of normal LV function, even a modest reduction in ejection fraction reflects significant contractile dysfunction. A brief early diastolic LV LA pressure gradient, often generating a rapid filling S3, and a mid-diastolic murmur masquerading as MS may occur in patients with pure severe MR as a result of very rapid flow of blood across a normal-sized mortal orifice. Chronic severe MR is defined by a regurgitant volume beyond 60 ml per beat, regurgitant fraction beyond 50%, and effective regurgitant orifice area beyond 0.40 centimeter square. All can be calculated on echo Doppler and color flow mapping, and sometimes on CMR. Symptoms and physical findings of a patient with chronic mild to moderate isolated MR are usually asymptomatic. They can have symptoms in the form of fatigue. Adjustmental dyspnea and orthopnea are the most prominent. Palpitations are common and may signify the onset of atrial fibrillation. Right-sided heart failure with painful hepatic congestion, ankle edema, distended neck veins, ascites, and secondary TR can occur in patients with MR who have associated pulmonary vascular disease and severe pulmonary artery hypertension. Acute pulmonary edema is common in patients with acute severe MR. A systolic thrill is often palpable in the cardiac apex. The LV is hyperdynamic with a brisk systolic impulse and a palpable rapid filling wave at the S3, and the apex beat is often displaced laterally, signifying cardiomegaly. Soft or absent S1 and an S3, and in severe MR, MDM. A systolic murmur of at least grade 3 to 4 intensity is the most characteristic auscultatory finding in chronic severe MR. It is usually pansystolic, most prominent at the apex. Sometimes radiates to axilla. However, in patients with ruptured chordae tendineae or primarily involvement of the posterior mitral leaflet with prolapse or flail, the regurgitant jet is eccentric, directed anteriorly, and it strikes the LA wall adjacent to aortic groove. In this situation, the systolic murmur is transmitted to the base of heart and therefore may be confused with the murmur of aortic stenosis. In patients with ruptured chordae tendineae, the systolic murmur may have a cooing or seagull quality, whereas a failed leaflet may produce a murmur with a musical quality. It is early systolic in acute severe AR. So, one has to remember in chronic severe MR it is a pansystolic murmur, but in acute severe MR it is early systolic. The clinical features, of course, the breathlessness caused by pulmonary congestion, fatigue by low cardiac output, edema, ascites by right-sided heart failure, and palpitation by atrial fibrillation. Again, the signs atrial fibrillation is caused by atrial dilatation, displaced apex beat by cardiomegaly, auscultation, apical systolic murmur due to regurgitation of blood from left ventricle to left atrium, soft S1 as the valve does not close properly, apical S3 due to rapid flow of blood into the left ventricle, crepitations, pulmonary edema due to left-sided heart failure, pleural effusion, right ventricular heave, raised JVP, and edema is due to pulmonary hypertension and right-sided heart failure. So these are the various signs and symptoms which can be correlated with underlying pathophysiology. And here classically all the signs of mitral regurgitation are depicted. You have got the soft S1 followed by a pansystolic murmur, then the second heart sound, and just beyond second heart sound you have got an S3. Of course, the investigations which are required, ECG usually reveals left atrial hypertrophy and atrial fibrillation. Chest X-ray, cardiomegaly, enlarged LA, pulmonary venous congestion, and sometimes pulmonary edema. Echo, of course, dilated LV, LA, and we have got the structural abnormalities of the mitral valve. Doppler detects mitral regurgitation and quantifies whether the regurgitation is mild, moderate, or severe. And cardiac catheterization confirmed these findings were basically utilized for ruling out associated coronary artery disease. ECG and chest X-ray, of course, ECG will reveal left atrial or biatrial enlargement, LV volume overload, and sometimes atrial fibrillation. X-ray, LV LA enlargement, that's LV cardiomegaly, pulmonary venous congestion, interstitial edema, curly B lines, mitral valve leaflet calcification, and mitral annular calcification can be seen. And this is the classical ECG, and you can see atrial fibrillation, and there is LV dilatation, LV hypertrophy with volume overload, and there is atrial fibrillation. Of course, the echocardiogram is the most important investigation which will detect the mechanism of mitral regurgitation and its hemodynamic severity. LV function can be assessed from LV end-diastolic and end-systolic volumes and ejection fractions. One has to remember even a slight dip in ejection fraction in presence of mitral regurgitation signifies severe LV dysfunction. Leaflet structure and function, caudal integrity, LA-LV size, annular calcification, and regional global LV systolic functions. One can look for MR jet and its severity and pulmonary artery pressure on echocardiogram. So it's very useful and most important investigation in assessment of mitral regurgitant patients. And here are the echo pictures. You can see the severe mitral regurgitation. So regurgitant jet is coming from mitral valve and going into the LA. These are the various views, and in all the views you can see the regurgitant mitral regurgitation. Treatment, of course, the vasodilator therapy is utilized in chronic severe MR, although its role is not very certain. In secondary MR, you have to use the drugs which helps in reversing the adverse cardiac remodeling, as RAS blockers including ARNI, beta blockers, they all reduce MR. So all patients can be put on that to prevent the adverse LV remodeling and decreasing LV size and decreasing MR. Decongestive therapy as per symptoms in heart failure, treat the underlying cause. Prophylaxis for rheumatic fever as per guidelines. Prophylaxis for infective endocarditis as per guidelines. And if there is atrial fibrillation, anticoagulation with NOACs or warfarin as per Chats versus score and as blood score for bleeding. Regarding surgery, patients with chronic severe primary MR are for surgical treatment. Often slowly progressive nature of the condition must be balanced against the immediate and long-term risk associated with surgery. The risks are significantly lower for the primary valve repair than the replacement. So, of course, repair is a better alternative than the replacement. Repair usually consists of valve reconstruction using a variety of valvuloplasty techniques and insertion of annuloplasty ring. Repair spares the patient with long-term adverse consequences of valve replacement, including thromboembolic and hemorrhagic complications in the case of mechanical prosthesis, late valve failure necessitating repeat valve replacement in case of bioprosthesis. Surgery for chronic severe primary MR is indicated once the patient is symptomatic and especially when the valve repair is not feasible. Surgery should also be recommended for asymptomatic patients with LV dysfunction characterized by an ejection fraction less than 60 or an LV end-systolic dimension more than 40 mm. Other indications for early consideration of mitral valve repair in the asymptomatic patients include recent onset AF, pulmonary hypertension, and a progressive decrease in LV ejection fraction or increase in LV end-systolic dimensions on serial imaging. Repair is feasible up to 95% of patients with myxomatous disease. Repair techniques include caudal transfer, creation of new cords, limited leaflet resection, and insertion of annuloplasty bands. Long-term durability is excellent. The incidence of preoperative surgery for failed primary repair is less than 1%. Surgery for patients with chronic ischemic MR most often involves a simultaneous coronary artery revascularization and now it can be done cath based with a transcatheter mitral clip insertion, and if that is not feasible, then repair and replacement. And here is an example of the mitral valve clip which can be utilized for that. Mortality rate for mitral valve surgery, MVR isolated, is 4.6. If it is associated with CABG, it goes to 10%. Repair mortality is much less, 1.2. Acute mitral incompetence, etiology of acute MR, inferior MI, most common cause, infective endocarditis, ischemia, and trauma. Clinically, these patients present with acute decompensated heart failure, presenting with severe pulmonary edema, tachycardia, dyspnea, murmur, harsh apical systolic starts with S1 and ending before S2. Treatment, stabilize the patient, and then surgical intervention. A word about mitral valve prolapse. It's the most common valvular disease in industrialized countries. 2.4% of the population has got the mitral valve prolapse. It may or may not be associated with regurgitation. No increased risk of stroke, syncope, or sudden death when compared to patients without prolapse. Clinically, most patients are asymptomatic. Symptomatic patients may present with a non-exertional fatigue and dyspnea. Clinical examination might reveal a mid-systolic click and murmur, which may increase to S2. Diagnosis is established by echocardiography. Tentatively, treatment is rarely required if your patient is symptomatic with atypical chest pain. Beta blockers can be utilized, and of course, avoidance of alcohol, caffeine, tobacco might help these patients. So, this covers your mitral valve disease, including both mitral stenosis, mitral regurgitation, mitral valve prolapse, and acute mitral